Hello dear students, I hope you are good. Today I am going to present my fourth lecture of urology. So our fourth lecture of urology are urogenital trauma and modern andrology, emergency medicine and management. About 10% of all injuries seen in emergency room involve the genitourinary system to some extent. Many of them are subtle and difficult to define and require great diagnostic expertise. Early diagnosis is essential to prevent serious complications. Initial assessments should include control of hemorrhage and shock along with resuscitation and as required. Resuscitation may require intravenous lines and urethral catheter in seriously injured patients. In men, before the catheter is inserted, the urethral meatus should be examined carefully for the presence of blood. The history should include detailed description of the accident. The abdomen and genitalia should be examined for evidence of contusions or subcutaneous hematomas, which might indicate deeper injuries to the retroperitoneum and pelvic structures. Fractures to the lower ribs are often associated with renal injuries, and pelvic fractures often accompany bladder and urethral injuries. Diffuse abdominal tenderness is consistent with perforated bowel, free intraperitoneal blood or urine, or retroperitoneal hematoma. Patients who do not have life-threatening injuries and those whose blood pressure is stable can undergo more deliberate radiographic studies. This provides more definitive staging of the injury. In this picture we can see the location of genitourinary traumas in percentage. As we see here, most often genitourinary traumas seen in kidneys, but very rarely we see in ureters. Injuries to the kidney. Renal injuries are the most common injuries of the urinary system. The kidney is well protected by heavy lumbar muscles, vertebral bodies, ribs, and the viscera anteriorly. Fractured ribs and transverse vertebral process may penetrate the renal parenchyma or vasculature. Most injuries occur from automobile accidents or sporting mishaps, chiefly in men and boys. Kidneys with existing pathologic conditions such as hydronephrosis or malignant tumors are more readily ruptured from mild tumors. Blunt trauma directly to the abdomen, flank, or back is the most common mechanism, accounting for 80 to 85% of all renal injuries. Trauma may result from motor vehicle accidents, fights, falls, and contact sports. Vehicle collisions at high speed may result in major renal trauma from rapid deceleration and cause major vascular injury. Gunshot and knife wound cause most penetrating injuries to the kidney. Any such wound in the flank area should be regarded as a cause of renal injury until proved otherwise. Associated abdominal visceral injuries are present in 80% of renal penetrating wounds. In this picture we can see two different types of renal injury. One is blow to abdomen, another is falling to a sitting position. As we see in the second image, in a falling position there is a tear of renal pedicule can be happen. In this picture we can see the grades of renal traumas, and the next picture also explains more about the grades of the renal traumas, which starting from 1 to grade 5, and this slide explain in detail the grading of renal traumas. Microscopic or gross hematuria following trauma to the abdomen indicates injury to the urinary tract. It bears repeating that stab or gunshot wounds to the flank area should alert the physician to possible renal injury whether or not hematuria is present. Some cases of renal vascular injury are not associated with hematuria. These cases are almost always due to rapid deceleration accidents and are an indication for imaging studies. The degree of renal injury does not correspond to the degree of hematuria, since gross hematuria may occur in minor renal trauma and only mild hematuria is a major trauma. Patients with gross hematuria or microscopic hematuria with shock should undergo radiographic assessment. Symptoms. There is usually visible evidence of abdominal trauma. Pain may be localized to one flank area or over the abdomen. Associated injuries such as ruptured abdominal viscera or multiple pelvic fracture also cause acute abdominal pain and may obscure the presence of renal injury. Catheterization usually reveals hematuria. Retroperitoneal bleeding may cause abdominal distension, ileus, nausea, and vomiting. Initially, shock or signs of large loss of blood from heavy retroperitoneal bleeding may be noted. Ecchymosis in the flank or upper quadrant of the abdomen is often noted. Lower rib fracture are frequently found. Diffuse abdominal tenderness may be found in palpation. An acute abdomen usually indicates free blood in the peritoneal cavity. A palpable mass may represent a large retroperitoneal hematoma or perhaps urinary extravasation. If the peritoneum has been torn, free blood may be noted in the peritoneal cavity, but no palpable mass will be evident. The abdomen may be distended and bowel sound absent. In laboratory finding, microscopic or gross hematuria is usually present. Hematocrit may be normal initially, but a drop may be found when serial studies are done. These findings represent persistent retroperitoneal bleeding and development of a large retroperitoneal hematoma. Persistent bleeding may necessitate operation. Staging and X-ray findings. Staging of the renal injuries allows a systemic approach to these problems. Adequate studies help define the extent of injury and dictate appropriate management. For example, blunt trauma to the abdomen associated with gross hematuria and a normal urogram requires no additional renal studies. However, non-visualization of the kidney requires CT scan or determine whether renal vascular injury exists. Ultrasonography and retrograde urography are of little use initially in the evaluation of renal injuries. Staging begins with an abdominal CT scan in renal injuries. This non-invasive technique clearly defines parenchymal lacerations and urinary extravasation, show the extent of the retroperitoneal hematoma, and also give us information about organs such as the pancreas, spleen, liver, and bowel. If CT scan is not available, an intravenous pyelogram (IVP) can be obtained. The major cause of non-visualization on an IVP are total pedicle avulsion, arterial thrombosis, severe contusion causing vascular spasm, and absence of the kidney. In this image, we see on the left image, we see computer tomography, especially contrast-enhanced computer tomography, shows the right stub wound of the kidney, and there is obvious extravasation of the urine to retroperitoneal area, and there is a large retroperitoneal hematoma. On the right side, we see IVP film, which shows on the left kidney there is a retroperitoneal extravasation of the urine because of this renal trauma. Complications. Early complications. Hemorrhage is perhaps the most important immediate complications of renal injury. Heavy retroperitoneal bleeding may result in rapid exsanguination. Patient must be observed closely with careful monitoring of blood pressure and hematocrit. Complete staging must be done early. The size and expansion of palpable masses must be carefully monitored. Persistent retroperitoneal bleeding or heavy gross hematuria may require early operation. Urinary extravasation from renal fracture may show as an expanding mass in the retroperitoneum. These collections are prone to abscess formation and sepsis. A resolving retroperitoneal hematoma may cause slight fever, but higher temperature suggests infection. A perinephric abscess may form, resulting in abdominal tenderness and flank pain. As a late complication, we can see hypertension, hydronephrosis, arteriovenous fistula, calculus formation, renal atrophy, and pyelonephritis. Heavy late bleeding may occur in 1 to 4 weeks after injury. Late pathologic findings. As a late pathologic findings, we can see urinoma, hydronephrosis, arteriovenous fistula, and renal vascular hypertension, as we talked in a previous slide. As a treatment, we have emergency measures. The objectives of early management are prompt treatment of shock and hemorrhage, complete resuscitation, and evaluation of associated injuries. As a surgical measures, minor renal injuries from blunt trauma occurs 85% of causes and do not usually require operation. Bleeding stops spontaneously with bed rest and hydration. Cases in which operation is indicated include those associated with persistent retroperitoneal bleeding, urinary extravasation, and renal pedicle injuries. Aggressive preoperative staging allows complete definition of injury before operation. Penetrating injuries should be surgically explored. A rare exception in this rule is when staging has been complete and only minor parenchymal injury with no urine extravasation is noted. Treatment of complications. Retroperitoneal urinoma or perinephric abscess demands prompt surgical drainage. Malignant hypertension requires vascular repair or nephrectomy. Hydronephrosis may require surgical correction of nephrectomy or nephrectomy. Angioembolization done by interventional radiology provides excellent control of active bleeding from the kidney. Prognosis. With careful follow-up, most renal injuries have an excellent prognosis with spontaneous healing and return of renal function. Now we will talk about injuries to the ureter. Ureteral injury is rare but may occur usually during the course of a different pelvic surgical procedures or as a result of stab or gunshot wounds. Rapid deceleration accidents may abuse the ureter from the renal pelvis. Endoscopic basket manipulation of ureteral calculi may also result in ureteral injury. A large pelvic mass may displace the ureter laterally and engulf in the reactive fibrosis. This may lead to ureteral injury during dissection since the organ is anatomically malpositioned. Inflammatory pelvic disorders may involve the ureter in a small way. Extensive carcinoma of the colon may invade areas outside the colon wall and directly involve the ureter. Thus, resection of the ureter may be required along with resection of the tumor mass. Devascularization may occur with extensive pelvic lymph node dissections or after radiation therapy to the pelvic for pelvic cancer. In these situations, ureteral fibrosis and subsequent stricture formation may develop along with ureteral fistulas. Endoscopic manipulations of a ureteral calculus with a stone basket or ureteroscope may result in ureteral perforations or avulsion. Pathogenesis and pathology. The ureter may be inadvertently ligated and cut during difficult pelvic surgery. In such cases, sepsis and severe renal damage usually occur postoperatively. If a partially divided ureter is unrecognized at operation, urinary extravasation and subsequent buildup of a large urinoma will ensue, which usually leads to ureterovaginal or ureterocutaneous fistula formation. Intraperitoneal extravasation of urine can also occur, causing ileus and peritonitis. After partial transection of the ureter, some degree of stenosis and reactive fibrosis develops with concomitant mild to moderate hydronephrosis. Symptoms. If the ureter has been completely or partially ligated during operation, the postoperative course is usually marked by fever, as well as lower quadrant pain. Such patients often experience paralytic ileus with nausea and vomiting. If ureterovaginal or cutaneous fistula develops, it usually does so within the first 10 postoperative days. Ureteral injuries from external violence should be suspected in patients who have sustained stab or gunshot wounds to the retroperitoneum. The mid portion of the ureter seems to be the most common site of penetrating injury. The acute hydronephrosis of a totally ligated ureter results in severe flank pain and abdominal pain with nausea and vomiting early in the postoperative course and with associated ileus. Signs and symptoms of acute peritonitis may be present if there is urinary extravasation into the peritoneal cavity. Laboratory finding. Ureteral injury from external violence is manifested by microscopic hematuria in 90% of cases. Urinalysis and other laboratory studies are of little use in diagnosis when injury has occurred from other causes. IVP or delayed abdominal spiral CT scan should be done. A plain film of the abdomen may demonstrate a large area of increased density in the pelvis or in an area of retroperitoneum where injury is suspected. After injection of contrast material, delayed excretion is noted with hydronephrosis. Partial transection of the ureter results in more rapid excretion. But persistent hydronephrosis is usually present and contrast extravasation at the site of injury is noted on delayed films. In acute injury from external violence, the excretory urogram usually appears normal with very mild illness down to the point of the extravasation at the ureteral transection. Retrograde ureterography demonstrates the exact site of obstruction or extravasation. Ultrasonography outlines hydroureter or urinary extravasation as it develops into a urinoma and is perhaps the best means of ruling out ureteral injury in the early postoperative period. Radionuclide scanning demonstrates delayed excretion of the injured site, with evidence of increasing count owing to accumulation of urine in the renal pelvis. It is great benefit, however, is in the assessment of renal function after surgical correction. In this image, actually this is an IVP image, we can see the extravasation of urine in the mid-ureteral portion. As we see, the renal pelvis and calyces are filled with contrast, and ureter comes down until the mid portion of the ureter, and there is an obvious extravasation. Differential diagnosis. Postoperative bowel obstruction and peritonitis may cause symptoms similar to those of acute ureteral obstruction from injury. Fever, acute abdomen, and associated nausea and vomiting following difficult pelvic surgery are definite indication for screening sonography or IVP to establish whether ureteral injury has occurred. Deep wound infection must be considered postoperatively in patients with fever, ileus, and localized tenderness. The same findings are consistent with urinary extravasation and urinoma formation. Acute pyelonephritis is the early postoperative period may also result in findings similar to those of ureteral injury. Sonography shows normal results and urography shows no evidence of obstruction. Complications. Ureteral injury may be complicated by stricture formation with resulting hydronephrosis in the area of injury. Chronic urinary extravasation from unrecognized injury may lead to formation of a large retroperitoneal urinoma. Pyelonephritis from hydronephrosis and urinary infection may require prompt proximal drainage. Treatment. Prompt treatment of ureteral injuries is required. The best opportunity for surgical repair is in the operating room when the injury occurs. If the injury is not recognized until 7 to 10 days after the event and no infection, abscess, or other complication exists, immediate re-exploration and repair are indicated. Proximal urinary drainage by percutaneous nephrostomy should be considered if the injury is recognized late or if the patient has significant complications that make immediate reconstruction unsatisfactory. The goal of ureteral repair are to achieve complete debridement of tension-free spatulated anastomosis, watertight closure, ureteral stenting, and retroperitoneal drainage. In this image we can see two different types of the surgery technique. In the first picture we see the operation technique of transureterostomy. Why we do this? Because sometimes mid-ureteral trauma leaves us very small ureter, and then we need to connect to make anastomosis to transureterostomy, and actually this type of anastomosis is site to end anastomosis, end to site anastomosis. In the second image we see end primary ureterostomy. When we do this, especially when during the operation, if surgeon traumatizes the ureter and notices it during the procedure, they ask urologists to come and repair the ureter by ureterostomy. This is end-to-end anastomosis. First of all, we do some small spatulation and we use vicryl sutures to do end-to-end anastomosis just after placing a double J stent to collecting system. And after the procedure, we remove the double J stent generally after 3 to 4 weeks postoperatively. In these two images, we see two different techniques after lower ureteric trauma. First one is sausage procedure, which we use the urinary bladder to lift it and to make anastomosis to source muscle, and then use some part and connect the lower part of ureter to the bladder. And the second image shows us, picture shows us the bladder tube flap technique when there is lower part of the ureter damaged, then we can use some flap from the bladder and make it tubularize it and use it as a lower ureter. And all of these techniques needs a double J placement during anastomosis. On the next image, we see the complete avulsion of ureter starting from upper portion of the ureter to lower portion. So in this case, we have the chance to replace the ureter with small bowel. This image shows the bowel replacement of the ureter, which we call ileal ureter. Lower ureteral, in this slide we also can see the explanation of some of these techniques to lower ureteral injuries, mid-ureteral injuries, and to injuries to upper ureter. The prognosis for ureteral injury is excellent if the diagnosis is made early and prompt corrective surgery is done. Delay in diagnosis worsens the prognosis because of infection, hydronephrosis, abscess, and fistula formation. And now injuries to the bladder. Bladder injuries occur most often from external force and are often associated with pelvic fractures. Iatrogenic injury may result from gynecologic and other extensive pelvic procedure, as well as from hernia repair and transurethral operations. The bony pelvis protects the urinary bladder very well. When the pelvis is fractured by blunt trauma, fragments from the fracture site may perforate the bladder. These perforations usually result in extraperitoneal rupture. If the urine is infected, extraperitoneal bladder perforations may result in deep pelvic abscess and severe pelvic inflammation. When the bladder is filled to a near capacity, a direct blow to the lower abdomen may result bladder disruption. This type of disruption is ordinarily intraperitoneal, since the reflection of the pelvic peritoneum covers the dome of the bladder. A linear laceration will allow urine to flow into the abdominal cavity. If the diagnosis is not established immediately and if the urine is sterile, no symptoms may be noted for several days. If the urine is infected, immediate peritonitis and acute abdomen will develop. In this slide, we see the mechanism of the vesical injury, as we see the injuries coming from the abdomen, lower abdomen. Clinical findings. Pelvic fracture accompanies bladder rupture in 90% of cases. The diagnosis of pelvic fracture can be made initially in the emergency room by lateral compression of the bony pelvis, since the fracture site will show crepitus and be painful to the touch. There is usually a history of lower abdominal trauma in the symptoms. Blunt injury is the usual cause. Patients ordinarily are unable to urinate, but when spontaneous voiding occurs, gross hematuria is usually present. Most patients complain of pelvic or lower abdominal pain. Signs, heavy bleeding associated with pelvic fracture may result in hemorrhage, shock, usually from venous disruption of pelvic vessels. Evidence of external injury from a gunshot or stab wound in the lower abdomen should make one suspect bladder injury, manifested by marked tenderness of the suprapubic area and lower abdomen. An acute abdomen may occur with intraperitoneal bladder rupture. Laboratory finding, as catheterization usually is required in patient with pelvic trauma, but not if bloody urethral discharge is noted. Bloody urethral discharge indicates urethral injury, and a uretherogram is necessary before catheterization. When catheterization is done, gross or less commonly microscopic hematuria is usually present. Urine taken from the bladder at the initial catheterization should be cultured to determine whether infection is present. A plain abdominal film generally demonstrates a pelvic fracture. A CT scan should be obtained to establish whether kidney and urethral injury are present. Bladder disruption can be seen on cystography. The bladder should be filled with 300 ml of contrast material and a plain film of the lower abdomen obtained. Contrast medium should be allowed to drain out completely, and a second film of the abdomen should be obtained. The drainage film is extremely important because it demonstrates areas of extraperitoneal extravasation of blood and urine that may not appear on the filling film. With intraperitoneal extravasation, free contrast medium is visualized in the abdomen, highlighting bowel loops. CT cystography is an excellent method for detecting bladder rupture. However, retrograde filling of the bladder with 300 ml of contrast medium is necessary to distend the bladder completely. In this image we see cystography film. The cystography film shows the extraperitoneal bladder rupture, and we see here the contrast extravasation of extraperitoneal. Surgical measures. A lower midline abdominal incision should be made. As a bladder is approached in the midline, a pelvic hematoma, which is usually lateral, should be avoided. Entering the pelvic hematoma can result in increased bleeding from release of tamponade. The bladder should be opened in the midline and carefully inspected. After repair, a suprapubic cystostomy tube is usually left in place to ensure complete urinary drainage, and the placement of urethral catheter is also important. Extraperitoneal bladder rupture can be successfully managed with urethral catheter drainage only. Large blood clots in the bladder or injuries involving the bladder neck should be managed surgically. Intraperitoneal rupture should be repaired via a transperitoneal approach after careful transvesical inspection and closure of any other perforations. Pelvic fracture, stable fracture of the pelvis, pubic ram is usually present. In such cases, the patient can be ambulatory within 4 to 5 days without damage or difficulty. Unstable pelvic fracture requires external fixation, have a more protracted course. Complications. A pelvic abscess may develop from extraperitoneal bladder rupture. If the urine becomes infected, the pelvic hematoma becomes infected too. Intraperitoneal bladder rupture with extravasation of urine into the abdominal cavity causes delay peritonitis. Partial incontinence may result from bladder injury when the laceration extends into the bladder neck. Prognosis with appropriate treatment, the prognosis is excellent. The suprapubic cystostomy tube can be removed within 10 days, and the patient can usually void normally. Injuries to the urethra. Urethral injuries are common and occur most often in man, usually associated with pelvic fractures or straddle type of falls. They are rare in women. Various parts of the urethra may be lacerated, transected, and contused. Management varies according to the level of injury. The urethra can be separated in two broad anatomic divisions as shown in here: posterior and anterior urethra. Injuries to the posterior urethra. The membranous urethra passes through the pelvic floor and voluntary urinary sphincter and is a portion of the posterior urethra most likely to be injured. When pelvic fracture occurs from blunt trauma, the membranous urethra is shattered from the prostatic apex at the prostato-membranous junction. The urethra can be transected by the some mechanism at the interior surface of the membranous urethra. This image shows the injury of posterior urethra. As we see here, prostate and posterior urethra has been avulsed completely, and there is huge hematoma collected in deep pelvis. Clinical findings. Symptom patient usually complain lower abdominal pain and inability to urinate. A history of crushing injury to the pelvis is usually obtained. Blood at the urethral meatus is the single most important signs of urethral injury. The importance of this finding cannot be overemphasized, because an attempt to pass the urethral catheter may result in infection of the periprostatic and perivesical hematoma and conversion of an incomplete laceration to a complete one. The presence of blood at the external urethral meatus indicates that immediate urethrography is necessary to establish the diagnosis. Suprapubic tenderness and the presence of pelvic fracture are noted on physical examination. A large developing pelvic hematoma may be palpated. Perineal or suprapubic contusions are often noted. Rectal examination may reveal a large pelvic hematoma with the prostate displaced superiorly. X-ray findings. Fractures of the bony pelvis are usually present. A urethrogram shows the site of extravasation at the prostatomembranous junction. Instrumental examination. The only instrumentation involved should be for urethography. Differential diagnosis. Bladder rupture may be associated with posterior urethral injuries in approximately 20% of cases. Cystography cannot be done preoperatively since the urethral catheter should not be passed. Careful evaluation of bladder at operation is necessary. Complications, stricture, impotence, and incontinence are the complications of posterior urethral injury. And this is urethography image shows that the posterior urethral injury, which the contrast extravasation in posterior urethra. Treatment. Emergent measures. Shock and hemorrhage should be treated. Surgical urethral catheterization should be avoided. As an immediate management, initial management should consist of suprapubic cystostomy to provide urinary drainage and should maintain in place for about 3 months. Incomplete laceration of the posterior urethra heals spontaneously, and at the suprapubic cystostomy can be removed within 2 to 3 weeks. Delayed urethral reconstruction. Reconstruction of the urethra after prostatic disruption can be undertaken within 3 months, assuming there is no pelvic abscess or other evidence of persistent pelvic infection. Before reconstruction, a combined cystogram and urethrogram should be done to determine the exact length of the resulting urethral stricture. This stricture usually is about 1 to 2 cm long and situated immediately posterior to pelvic bone. The preferred approach is a single-stage reconstruction of the urethral rupture defect with direct excision of the strictured area and anastomosis of the bulbous urethra directly to the apex of the prostate. A 16-French silicone urethral catheter should be left in place along with a suprapubic cystostomy. Catheters are removed within a month and the patient is then able to void. In this image we see the voiding cystogram after has taken after the catheter removal from urethroplasty. Injuries to the anterior urethra. The anterior urethra is a portion distal to urogenital diaphragm. Straddle injury may cause laceration or contusion of the urethra. Self-instrumentation or iatrogenic instrumentation may cause partial disruption. Contusion or lacerational traumas also we see here. Contusion of the urethra is a large urethra is a sign of crush injury without urethral disruption. Perineal hematoma usually resolves without complication. A severe straddle injury may result laceration of part of the urethral wall, allowing extravasation of urine. If the extravasation is unrecognized, it may extend into the scrotum along the penile shaft and up to the abdominal wall. It is limited to only by Colles fascia and often result in sepsis, infection and serious morbidity. In this image we can see the sample to straddle injury, and after the straddle injury there is a huge hematoma can be seen in perineal and scrotal area. Symptoms: there is usually a history of fall and some cases a history of instrumentation. Bleeding from the urethra is usually present. The perineum is as a sign, the perineum is very tender. A mass may be found as may blood the urethral meatus. Rectal examination reveals a normal prostate. In a laboratory finding, blood loss is not usually excessive, particularly if secondary injury has occurred. The white count may be elevated with infection. In this film we see a ureterogram, ruptured bulbar urethra following straddle injury, extravasation on ureterogram. As a complication, heavy bleeding from the corpus spongiosum injury may occur in a perineum as well as through the urethral meatus. Pressure applied to the perineum over the site of the injury usually controls bleeding. If hemorrhage cannot be controlled, immediately operation is required. The complications of urinary extravasation are chiefly sepsis and infection. Aggressive debridement and drainage are required if there is infection. Stricture at the site of injury is a common complication, but surgical reconstruction may be required unless the stricture significantly reduce urinary flow rates. Urethral contusion treatment. The treatment with urethral contusion shows no evidence of extravasation and the urethra remains intact. After ureterography, if the patient is allowed to void and if the voiding occurs normally without pain or bleeding, no additional treatment is necessary. Urethral laceration treatment. Instrumentation of the urethra following ureterography should be avoided. Percutaneous suprapubic cystostomy can be inserted, allowing complete urinary diversion while the urethral laceration heals if only minor extravasation is noted on the ureterogram. A voiding study can be performed within 7 days after cystostomy catheter to search for extravasation. In more extensive injuries, one should wait 2 to 3 weeks before doing a voiding study through the suprapubic catheter. Healing at the site of injury may result in a stricture formation. Most of these strictures are not severe and do not require surgical reconstruction. The suprapubic cystostomy catheter may be removed if no extravasation is documented. Prognosis: urethral stricture is a major complication, but in most cases does not require surgical reconstruction. If stricture resolves, urinary flow rates are poor and urinary infection and urethral fistula are present. Reconstruction is required. Injuries to the penis, we see it is quite rare. Disruption of the tunica albuginea of the penis can occur during sexual intercourse. At presentation, the patient has penile pain and hematoma. This injury should be surgically corrected. Injuries to the scrotum, superficial lacerations to the scrotum may be debrided and closed primarily. Blunt trauma may cause local hematoma and ecchymosis, but these injuries usually resolve without difficulty. One must be certain that testicular rupture has not occurred. Injuries to the testis. Blunt trauma to the testis cause severe pain and often nausea and vomiting. Lower abdominal tenderness may be present. A hematoma may surround the testis and make delineation of its margin difficult. Ultrasonography can be used as an aid to better define the organ. If rupture has occurred, it should be surgically repaired. Modern andrology and male sexual dysfunction and male infertility. Now we moved on our second part of our lecture. Erectile dysfunction, premature rapid ejaculation, retrograde ejaculation, priapism and Peyronie's disease, as we see here, are all the male all included to male sexual dysfunction. Male infertility and associated factors. Male infertility associated factors are as shown in this slide. Mainly we deal with varicocele in male fertility. Also we sometimes see hypogonadism patients and any other forms of infertility we also see very rarely. As we are talking about andrology, we have to talk about erectile dysfunction. In this image there is anatomy of the penis, and on the next image we can see the anatomy of penis as well as the vessels which helps to erection. Erectile dysfunction defined as a persistent inability to attain and maintain an erection sufficient to permit satisfactory to sexual performance. Epidemiology in the Massachusetts male aging study and community-based survey of men between 40 to 70 years of age, 52% of respondents reported some degree of ED. Risk factors are included obesity, diabetes, dyslipidemia, metabolic syndrome, lack of experience, and smoking. A classification of ED mostly used encompasses organic, psychogenic, and mixed etiologies. Now, ED were believed to be psychogenic, but as well as organic, like mixture. Organic ED could be neurogenic, hormonal, arterial, cavernosal, and drug-induced. Diagnosis. The management of ED is built on a patient-centered and evidence-based principle. Differentiate between organic and psychogenic causes is important. A focused physical examination is performed on each patient, assessing the genitourinary, endocrine, and neurologic and vascular systems, and includes a complete genital examination. Recommended tests include fasting glucose, lipid profile, and morning testosterone. Colodoplex ultrasound, the most popular vascular assessment of ED, is utilized when accurate vascular diagnostic testing is indicated. It consists of an intracavernous pharmac test and measurement of blood flow by colodoplex duplex ultrasound. Oral pharmacogenetic therapy. Phosphodiesterase inhibitors like sildenafil, vardenafil, and tadalafil, the three selective PDE5 currently approved for clinical use. Intracavernous injections, we can use papaverine and alpostatil as an intracavernous injection agents. Vacuum construction device also helps to obtain erection. Surgical treatment. If our all non-surgical treatment fails, then we can apply for a surgical treatment. As a surgical treatment, generally we perform or we place penile prosthesis, but sometimes penile vascular surgery like such arterial reconstructive surgery or penile venous surgery is also indicated. And in this image we see there is two different type of penile prosthesis. There is mainly used two type of penile prosthesis. The first one is inflatable penile prosthesis, which we place a pump into the scrotum. With the help of this pump, patient can get erection. And in this semi-rigid penile prosthesis is manually adjusted. When we talk about andrology, we also will talk about male infertility. Infertility generally described as a failure of conceive despite 1 year of regular unprotected intercourse. Approximately 15% of duplex will experience infertility, and of these 20 to 30% of these infertility due to male factors. In general, male infertility is defined by abnormality on a semen analysis. However, other issues can be contributed to infertility despite normal semen. Physical examination is important for infertility patients, as described in this part. Semen analysis. In this chart, we see the minimal standards for semen analysis for men. Laboratory testing is an important part of the male infertility evaluation. As a laboratory test, we use testosterone, FSH, LH, and prolactin tests. Varicocele. When we talk about male infertility, most of the time we see varicoceles in the male during physical examination. Varicocele is defined as a dilated and incompetent vein within the pampiniform plexus of spermatic cord. Varicocele has been described as the most commonly surgically correctable cause of male subfertility. This is a disease that develops during puberty. Varicocele is only rarely detected in boys smaller than 10 years of age. A self-studied varicocele is found in 15% of healthy young men. In contrast, the incidence of left varicocele is subfertile men approaches 40%. Bilateral varicoceles are uncommon in healthy men. An accurate physical examination remains the cornerstone of varicocele diagnosis. Several anatomic features contribute to the predominance of left-sided varicoceles, and this is explained in this slide. Varicoceles are associated with testicular atrophy, and varicocele correction can reverse atrophy in adolescents. There is strong evidence that the varicocele affects semen quality. Varicocele can cause abnormalities in concentration, motility, and morphology. However, deficits in motility can be the most profound. The finding of semen abnormalities constitutes the most common indication for varicocele surgery in infertile men. The mechanism by which varicocele exerts can affect on the testicle remains unclear. Several theories has been postulated. The most intriguing theory of how varicoceles affect testis function invokes an inhibition of spermatogenesis through the reflux of warm corporeal blood around the testis. With disruption of the normal countercurrent heat exchange balance and evaluation of intratesticular temperature. Scrotal Doppler ultrasonography can help us to diagnose the varicocele and also to diagnose the grading of the varicocele. As a treatment, the association of varicocele with male infertility is well established. Several treatment modalities, both surgical and non-surgical, are available for varicoceles. These include ligation of the veins through the retroperitoneal, inguinal, or subinguinal approaches. Percutaneous embolization and laparoscopy also described. The common goal of all treatment is to stop the retrograde flow of venous blood through the internal spermatic vein. Treatment improves sperm quality. In this chart we see the improvement of semen quality after the procedures or after the treatment of varicocele in different methods, with different methods. There is also medical therapies for infertility, such as testosterone excess deficiency, FSH, and human chorionic gonadotropin treatment, clomiphene citrate, and antioxidant therapy. Epididymal sperm aspiration or testicular sperm retrieval can be done the men who are azoospermic. What is azoospermy? Azoospermy is the lack of spermatozoids actually in sperm. And now we have finished our 4th lecture, and thank you for your attention. I hope you learned a lot from this lecture, especially about urogenital traumas, as well as male sexual dysfunction and male infertility. Stay well.